Hello? Hello? Anyone here?
Yes. Hi, how are you?
I'm pretty good. Hey, Omar, can we turn off the stream? Where is everyone? Welcome, Gio. I'm the host of this meeting.
Excuse me. We'll start at 9:30, please.
Who is the host here, actually? When are we starting?
In 2 minutes time.
Joe, what is on your screen?
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody.
All right, what's being drawn on the screen? All right, whoever's doing it, let's please shut it down here.
Assalamu alaikum wa rahmatullah. Good evening, everybody. I hope there is no kids with us in this meeting. So please, everybody should respect himself. It's my pleasure to introduce Dr. Omar Altamimi. He is the consultant pediatric cardiologist, interventionist. He is working in KFMC, and he is going to talk about the pulmonary hypertension in adult congenital heart disease. I wish everybody in this meeting is coming to get.
I'm back. Sorry, I just do my thing. Doing that.
So I wish everybody is coming here to get a benefit, not to make troubles. So Dr. Omar, is the mic is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, ladies and gentlemen. I am very happy to be here. I think there is some people who's going inside and playing with my slide. Miss Jo is her iPhone is there, and we will kick her out from the meeting soon.
That's not me. Someone is hacking. Someone is hacking me. Someone is hacking me.
Okay, come out, get out, and come back again, please. Okay, we'll start our meeting. This is it's really it's not good to have people who's just coming, not respecting the science and the people. But anyway, let's start. We'll try our best. So the congenital heart disease I'm talking about today, because today we are in the week of congenital heart diseases, and it's our pleasures in our society to welcome everybody concerned and caring for congenital heart diseases. And we are very happy to share with you the information which is we have it, and really we hope some of you to be ready and share with us the next presentation. We invited several people to join us in this monthly meeting, and I hope people who's interesting to share the knowledge, their knowledge. Surely most of you and around me is having a huge knowledge. We can share with each others, and we can teach each others and give the benefit for each other. The sharing of the information is very helpful for us. And please, if you have any presentation which is you think that it's good for these meetings, please communicate with me or with Dr. Ahmed, and we will arrange for you a time during this year's to present your presentations. So pulmonary hypertension in adult congenital heart diseases is our presentation today. This is my declarations. And for most important things that in the Western countries now, the adult population of congenital heart diseases is more than the children. And this is very important and putting a lot of pressure on the environment to handle this patient. And we should care for them because really they are now become a big communities. Almost 90% of the children with congenital heart disease grow up to the adulthood, and 30% of the adult congenital patient have a disability, and they need not just only the cardiac care, they are having more than the cardiac care. Most of them, they have disability with cognitives, some of disability with others like motor or skeletal. And this is very important. And some of them, they are syndromatic. And you know that, all of you, this. And this is very important for us to care for this group of people, of patients, which is they are part of us. So the unoperated congenital heart disease is common in the third world and in our community in the Middle East area and in Africa. We have a lot of patients who is not operated, unfortunately, because of a shortage of resources. And really, this is making more communities also. So in a patient with pulmonary hypertension and congenital heart disease, it's range between 6 to 28% of the patient with congenital heart disease in adulthood, they have pulmonary hypertension. So pulmonary hypertension increase all the mortality. Any patient with pulmonary hypertension, what regardless it is just congenital heart disease with pulmonary hypertension, heart failure with pulmonary hypertension, even the chronic lung diseases with pulmonary hypertension, is usually you are putting more increase in the mortality rate. The pulmonary hypertension, such as other causes of other morbidity and comorbidity. So what happens in patients with pulmonary hypertension with congenital heart diseases? You have more admissions, more uses of resources and utilization, more admission to the ICU and to the ward. So this is very important. The patient with adult congenital, and this is a graph, this is a study from Asia, and this is very important to know what's happening. If the patient have an adult congenital heart diseases, and this is the ages, and you see that after the age of 40, they start declining down, and this is the patient with no congenital heart diseases, congenital heart diseases with no BH. This is a patient with BH. So this is patient with BH, really they start declining, or we are losing them earlier in the track of the congenital heart diseases. And this is very important to care for them. And we try with all our medications and treatment to improve the care to go to run in more better than what we are seeing here. In the congenital heart diseases, as you know, most of you they know that we are doing the congenital heart repair as in a childhood most of the time. We are aiming to biventricular repair, but we have single ventricle and we have 1.5 ventricle. So my talk will be in these two categories, single ventricle category and biventricular categories. To gain, because this is two different categories, regardless what they are surviving, they are totally adult congenital, but they are two different categories, and everyone is having his own problem. So in clinical approach, you should have high index of suspicion that there is possible the patient have pulmonary hypertension, because the pulmonary hypertension is non-specific symptoms, and usually the symptoms is because of exercise intolerance, change in the activity, using more sedentary life instead of moving and running. And this is very important in this time. Plus, we have some of our patients which have cognitive issues where they cannot complain and they have no way to communicate. So this is very important to have it, and that's why we are following the adult congenital for all the life, and that's we have to screen. One of the causes of to keep following them for life and to keep screening them. The heart failure, which is really unfortunately is a late stage of the pulmonary hypertension, and usually a right heart failures or a contam failures in a single ventricle. This is one of the presentation of the pulmonary hypertension and congenital heart diseases. In fact, imaging and sign of right heart hypertension is the most important RV dysfunction, and that's there is the most important is to know there is no clear time that, and that age, after that time, they will develop the pulmonary hypertension. There is nothing in literature until now. We know that this patient who has it, he will have it at the age of 20 or 30 or 40, but we know that we should be open mind for and high index of suspicions that they may develop pulmonary hypertension anytime. And when they have a complaint, you should be careful not to pass them easily. The classification of pulmonary hypertension doesn't change too much, but just it's very important for the people. In patients with congenital heart diseases, we are not just only having a congenital heart disease related pulmonary hypertension. They can have a connective tissue diseases, they can have HIV, they can have portal hypertension associated, they can have schistosomiasis. This is very important. This is very important to just not make your thinking about only the congenital heart disease cause of pulmonary hypertension, because they are adult and they can have the same thing, which is the adult having it, but because of the adult congenital heart diseases, also they can have more prevalence of the diseases than the normal populations. The second is the left-sided, which is the group 2, which is the heart failure causes of systemic or systolic or diastolic, and this is very important, plus the valvular heart diseases. The third category is the one with chronic lung or chronic hypoxia, and the same thing, adult, they can have it, regardless if they have a congenital heart disease or they don't have it, they can have it. The prevalence of the diseases and incidence is almost the same. So they can have the chronic obstructive lung diseases, they can have others hypoventilation syndromes. The fourth population is the chronic thromboembolic, and also another thing you should think about it. Maybe the chronic thromboembolic is higher than that in the congenital and cyanotic heart diseases, and you should think about any time they present it. The peripheral pulmonary stenosis usually is addressed in the childhood, and usually we do it in earlier life, but in the same time, some of them, they grow to the adulthood and they still have peripheral pulmonary stenosis and pulmonary hypertension. The group 5 is included the single ventricle there, and you just think about it when you are having a single ventricle patient. The most important is the hemodynamic, is that you have two categories. The one is pre-capillaries and the one is the post-capillary. The pre-capillary is the one that's happening in the pulmonary artery and the capillaries. And the post-capillary is usually in the venous side, in the venules, and we're talking about the left side heart diseases. And this is very important in the definition and the thinking and processing. And the patient with pre-capillary, usually we are giving advanced pulmonary hypertension medications. The patient with post-capillary, we have to treat the underlying causes. If it's the ventricular dysfunctions, if it's because of valvular heart diseases, if there is any issue in congenital issues associated like carotid triatum or anything, mitral stenosis. So we have to categorize the two patients, and this is from hemodynamics. I'm talking about it because in this type of patient, the BA pressure is mean BA pressure more than 20, which is less than 15, and the vascular resistant more than 3. This is in children. In adult, I will show you now. They change in the new guidelines of European guidelines to go to 2 Wood unit, and this is very important in these two categories. So from European guideline 2022, they put these things: the pre-capillary pH, the post-capillary pH, the combined one, and the unclassified. And I'm talking here in these categories. This is very important thing. The pre-capillary is containing in group 1, which is the pulmonary arterial hypertension. In the group 3, it's patient with respiratory heart diseases. And in the group 4 with chronic thromboembolic, and in the group 5, which is a basket of other diseases. So in this group, when you are having this categories of which is less than 15 and mean more than 20, the pulmonary vascular resistant in children who are using 3 Wood units per meter square, in the new guideline for adult is 2 Wood units. And this is very important to differentiate. And when you are pre-capillary, you have to look for, is it because of the group 1, which is pulmonary arterial hypertension, or because of the respiratory related or chronic thromboembolic. The 2 is the isolated post-capillary most of the time is because of the left heart. And usually in this type of patient, the wedge pressure is higher, and the vascular resistant in adults less than 2, and in the pediatrics less than 3. There is a sort of combined things, which is the patient who has more reactive pulmonary hypertension, although they have both capillaries, and this is combined one and still in the same definitions. The third one is unclassified PH, and we see it more in the pediatrics patient with congenital heart diseases and shunt. There is mean PA pressure is high, which is low, and the vascular resistance is low. And this is very important that this is common in congenital heart diseases and other hemoglobinopathies. In the Fontan populations, we have still in the old definitions. You know, this is Fontan is in the group 5, and usually we are using transpulmonary gradient. We'll speak about it in the end of this lectures as a single ventricle, and we are talking about transpulmonary gradient. It is the difference between the pulmonary pressure minus, because the Fontan is, there is no systole and diastole, it's usually one reading because there is no pulsatility. So the pulmonary pressure minus the wedge pressure, if it's more than 6, it's most probably it is causes of the pulmonary hypertension, and the pulmonary vascular resistant more than 3. For patient with adult congenital NPH, we will go by clinical and non-invasive imaging like echo, and when we are suspicious of that there is a pulmonary hypertension, we do right heart cath. Then we go, is it pre-capillary? And if it's pre-capillary, is it a group 1? And we'll go with the group 1 in the next slide. Is it a group 3 and 5? And group 3 and 5 is mainly, the group 3 is the patient who has more respiratory diseases, so OPD and others. Or is it a group 3, 4, which is chronic thromboembolic pulmonary hypertension? And with all this thing, which as we are doing it, group 1, we are BH approach. Is Zeminger cases, we are treating him as a Zeminger. The patient with post-op will be like idiopathic. And then we have another one, which is an incidental finding. CTF is treated by surgery. If the surgery is not effective, we're using balloon dilatations. And later on, if there is no effectiveness, we are using medical therapy. The post-capillary is very important. That patient, we are treating the underlying causes like diastolic dysfunction, systolic dysfunction, AV valve regurg is very important. Outflow obstruction is very important. And we look for the others, like also if there is a volume loaded ventricle. For a patient with pulmonary arterial hypertension, which is, pre-capillary one, which is group 1, and this is the subclasses of 1, 4 from the first group. This is very important. They subgroup it to group A, group B, group C, and D. The group A is Zeminger, and all of you know that Zeminger is a patient who has a pulmonary vascular resistant more than systemic vascular resistant. So they are reversing their shunt if there is a shunt at pre-tricuspid valve or even tricuspid valve, like a PSD or a ACHD or BDA. And this patient is a special, they are cyanotic at rest. The second is the patient which you see it with shunt, and they have the shunt is depending on the type of the shunt. Some of the shunt is operable or some non-operable. We may speak about the operability later on. The group C is the patient who has a small defect, and in adult, we are talking about ASD less than 2 cm or the PST less than 1 cm. This is a patient who has a group of who has pulmonary arterial hypertension with congenital heart disease, but it's a small defect which is unlikely to be the causes, and we treat them like idiopathic pulmonary arterial hypertension. Group D is a patient who's developed or persist pulmonary hypertension after we close the shunt. And because we thought that the decision was not that time, and that's what will happen. So let's go for group 1. Group 1, it is a Zeminger, or the group is the incidental. or the group which is we repair them and they develop pulmonary hypertension. So the recommendation is structural intervention is generally is contraindication. So nothing we do for them. If there is a PST or ASD incidental or Zimminger, we're not doing them. We're not closing them. We just give a treatment. So the most important we do if they are supportive care. If they are in class 1 of New York Heart Association, if they are in class 1, it's just supportive care and watchful monitor. If they are in class 2 or more, we are start initiation of medical therapy, and we're talking about advanced pulmonary hypertension medications. We'll speak about in the next slide. Group B, this is the patient with the congenital heart diseases, and this is very important to know them, that we do a right heart cath. We'll do the right heart cath. This is the patient with congenital heart diseases. They are not Alzheimer's cases. It's not a small defect, and it's not post-op. So we are doing a right heart cath to measure for pulmonary vascular resistance. If it's normal or slightly increased, then we close the defect. It's moderate one, we are individualizing the decisions. If it's high, then we are treat them like the A and C or D group, which is it's usually we go for New York Heart classes. If they are class 1, we are just watching them and support them. More than 1, it's more means 2 and more. We will go by advanced therapy. So this is the soft guidelines, which is very clear. If you do the cath with the patient who is having pulmonary vascular resistance in less than 4 Wood unit per meter square, or in the adult is less than total is 2.3. Usually we go and correct the defect. It is more than 8, it's unlikely to do it and should not be done. Between 4 and 8, we are individualize the approach, and we are taking patient by patient to help them if they can have other things. And most of the time, this can be done through vasoreactivities, sign of the heart failures, and in the others is the response to the treatment. Then the new guideline, 2022 for European guidelines for BH management, they put a special recommendation for patient with a defect, and they came with that first thing. The first important thing is you have QBQS is more than 1.5 to 1. So if it's less than 1.5 to 1, should not apply all this recommendation. First thing, you have to have a shunt pulmonary is systemic to pulmonary flow, systemic to pulmonary shunt with the ratio of the pulmonary to systemic flow is more than 1.5 to 1. Now, in patient with pulmonary vascular resistance less than 3, usually the recommendation is to go for closures. If the patient is that between 3 and 5, then we should, this is a class, become from class 1, class of recommendation of 1 to class 2A. Between if the BFR is more than 5, but it's come down to 5 after the treatment, which is that which is we heard before a long time, that treat and repair. After giving a treatment, it's dropped to less than 5, then it is what become class 2B. In patient with PST or BDA, but the BFR is more than 5, closure may be considered after careful evaluation for specialized center, and this is usually fake recommendations and where to go and how much high is it? High is it more than 5, more than 10, or that's it? But usually, most of the time, the people, they will give a treatment. If there is dropping in the vascular resistance and the shunt is increasing, that's it. But be careful that we are talking about, don't forget that it is the shunt should be from the start is more than 1.5 to 1. In fact, in the patient with more than 4 and there is with the treatment, there is no dropping and no significant change in the resistance, you should not close it. This is the new guideline, which is published recently in December 2022. Now, what should we do with the congenital heart disease and BH? In fact, we have 2 things, general measures and supportive measures. So what is the general measures? Maybe I will go with them in just next step, but just because I mentioned the European guideline, I have to mention the American guideline. The American guideline is very important. The American guideline, this is looking for, that is very important, that if you have a shunt at the ventricular level or ACHD level, pre-tricuspid or post-tricuspid valve, the shunt should be left to right. If it's right to left, then it is Iseminger. So we treat them as Iseminger. Forget this. Now, if it's left to right, then we look for the QB case. Still the same like the European, they should be 1.5 to 1. More than 1.5 to 1. If it's less than that, forget it. It will come down. But if it's more than that, more than 1.5 to 1, then this is a patient who's you are looking for the vascular resistant ratios. So the shunt, if it's right to left, it has become Iseminger. We're not touching him. If the QB case is less than 1.5 to 1, also it is going with the Iseminger cases, or a small shunt or incidental finding. We will not touch them. We are treating as with advanced. But let's say if there is a good shunt, is more than 1.5 to 1, then they look for the pulmonary vascular resistant. If the pulmonary vascular resistant less than 1/3 of systemic, and the pulmonary arterial systolic pressure less than half, this is they will go for closures. Now, if it's between 1/3 to 2/3 of systemic, the pulmonary vascular resistant, or the pulmonary arterial systolic pressure between 1/2 and 2/3 of the systemic, this is you have to do it case by case. But any patient with pulmonary vascular resistant more than the third of the systemic, or the pulmonary arterial pressure more than 2/3 of the systemic, then this is patient you should do nothing. You should stop doing anything for them and watch them if they are not in class. If they are in class 1 of New York Heart Association, if it's more than class 1, then you start advanced therapy. Now back to this the slide which I mentioned before. We have general measures and supportive measures. The general measures in congenital heart disease with pulmonary hypertension is the target physical exercise. What means target? They should avoid competitive sport, strenuous sport, which is really, it's very dangerous on them. Prevention of infections, and usually we are giving vaccinations, and you know that the extra vaccine like influenza vaccine, pneumococcal vaccine, and others. Endocarditis prophylaxis when it's needed. We encourage them to avoid smoking and drug abuse. We encourage them not to get pregnant, although some places, some of the people, they are talking about pregnancy in congenital heart disease and pulmonary hypertension, but still there is a risk of death for the mother and for the child. Preventive anemia and usually iron deficiency, even before anemia when there is iron store is depleted, you should always keep it under supervision and checking them irregular, so to fill the iron store deficiency. Prevent pulmonary air embolism, that we're using the filter. Prevent volume deficiency like exhausted exercising or dehydrations. And the most important also the psychological support, because most of them, they are higher in unemployment, they have social issue, difficult to make a relation and to maintain their relations. The other supportive measure, if no significant hemoptysis, oral anticoagulant could be considered if there is a pulmonary thrombosis. We should try oxygen supplementing. If they are improving with oxygen and their symptoms improve, we give it. If they're not, you don't need to give an oxygen because of low saturation. Phonosuction and eosinophilic fever only in symptomatic patient with hyperviscosity. It's you know that before that they are doing regular phonosuction. This is very risky, and usually there is a risk of stroke after phonosuctions in this patient. So avoiding it unless the patient is really symptomatic and he cannot respond to the medical therapy. In fact, if they have heart failure, we are treating the heart failure with anti-failure medications. In the patient with approach, which is I mentioned before, if it's a patient is a Minger, then he is in class 1, we are not doing anything. But if he's in class 2 or class 3, then you have to start first line treatment is endothelial receptor antagonist or PDE5 inhibitors. Then if it's not improving, then combine therapies. And if it's not improving, you go more for intravenous, subcutaneous, or oral inhaled prostacyclin. And this is very important. But with really intravenous, there is a risk with a Ziminger patient to have thromboembolic phenomena. Also, the infective endocarditis will be more damaging for the left side, and there is a risk of a stroke. So we try all the time to try oral, and if it's not, try subcutaneous. Maybe it's very helpful for them. Then, of course, you could consider lung and heart transplant. In the patient with which is the other one, which is group group C and D, we started with endothelial receptor BDF5. If they are class 2, if they are class 1, we are not starting because most of the recommendation in class 2. And we tried to make a combination therapy. Then, of course, you can start also the other subcutaneous. The other important thing you have to keep in your mind is surgical option may be available, including duct stenting for ductus patient with BDA or surgical bots shunt and atrial septostomy. It may help to remove, to improve the patient cardiac output and reduce, improve the RP dysfunction and RP failure, which is, we know that this is the most important causes of death in this patient. In this prognostic in the Ziminger syndrome, if you look for the first two tables, this is pre-tricuspid shunt and simple defect, and this is pre-tricuspid shunt or complex, post-tricuspid or complex. This is a post, and this is the pre-tricuspid, like ASD, partial anomalous, and they think they carry worse prognosis. The complex defect, single ventricle, is carrying poor prognosis. This is for us as a physician, we cannot modify them. But the thing which is you have to look for the oxygen saturations, transferrin saturation, which should be in high side. You can give a patient iron. New York Heart Association, you try to give more advanced therapy to shift him from class 3 and 4 to class 1 and 2. You try to slow down the symptom progression. You should do to avoid right heart failure, and in the same time the 6 minutes walk test. And we are using 400 meters, the 6 minutes, so that they can walk for 100 meters or more. The BMB and CRB also is very important as biomarker for heart failure, and the lower the BMB and the CRB, the better. The same thing from echo for the RP, which is the TAB-C and RA area, and the pericardial effusions. The same thing with the hemodynamic. We are looking for RA pressure and the cardiac index. This is very important things to look for them, and to keep your patient as possible as you can in the green side to help them and to improve their survival. So the take home from biventricular congenital heart diseases with pulmonary hypertension is the patient with pulmonary hypertension with congenital heart disease is different from pulmonary arterial hypertension with congenital heart diseases. The first one, you have to deal with the underlying causes. The second one is you have to use advanced therapy. Pulmonary arterial hypertension with congenital heart disease can be caused by other causes like connective tissue diseases, HIV, schistosomiasis, and etc. BH with congenital heart diseases have a meticulous evaluation in advanced center for possible operability or medical therapy. Advanced therapy indicated in class 2 and more for the trial of treat and repair with special cases. Ziminger syndrome and chronic disease with multi-organ involvement, avoid iron depletions, annual vaccine, and avoid venesections. The best therapy is to avoid pulmonary hypertension and through early operation and intervention in childhood. This is for the first part of this presentation. The second part will be talking about the single ventricle, Fontan, which is most of the people try to avoiding this topic because really it's a complex topic, and the data and the resources and the research is very limited on this complex single ventricle. But let's talk about it. We will try to touch all the variable data. And I hope I don't take this more longer than what you are expecting. So the pulmonary flow is depending on the central venous pressure, and this is very important. There is no pumping ventricles. And the central venous pressure also plus the pulmonary vascular resistance. So you need a low pulmonary vascular resistance to keep good pulmonary flow. And you know that pulmonary flow will determine the cardiac output. This is very important. The fontan is limited by the pulmonary, and you know the ventricular dysfunction and maladaptive pulmonary vascular remodeling, which is happening with the fontan because of no pulsatility. This is another important factor in the patient with a single ventricle. The survival is very important to know it. This is a study in 2017 and showing that this patient they are years after the fontan, which is, you know, most of us doing the fontan at around 2 to 3 years. You see that the red line is the mortality is going up with time. And you see that, sorry, the blue line is the survival, and you know that survival is going down and down with time. So what we are trying now to help to reduce this line and to improve this line. This is the aim and targeted as a physician. And the most patient with fontan is surviving into adulthood, but the mortality is increasing by around 10% every decade. It can be expected that less than 2/3 of the early survival of fontan will reach their 40s or 50. And this is very important. This is our mission to improve the survival. So what happened in the pre-fontan physiology, that excessive pulmonary flow plus the surgical reconstructions. The surgical construction like a Norwood procedure and aortic arch, others, there is a change in the elasticity of the ascending aorta, which is increasing the pressure loaded in the ventricle. So you have volume loaded and the pressure loaded, and this is going to lead to systolic and diastolic dysfunction. This is very important. The pulmonary flow and the pre-fontan, you have excessive flow, which is we need it in some time to enhance pulmonary vascular growth, but it's also causing volume load of the ventricle. The same thing, if you keep it for longer time, it can create a reversible pulmonary vascular remodeling. This is very important when you are doing a good shunt or big shunt, or you're leaving a patient with no controllable pulmonary flow, which is know that it's sometimes they came late for a single ventricle. They have good pulmonary artery size, but the problem is the volume loaded ventricle and the pulmonary remodeling. The underflow, this is very bad. When you are putting a small shunt with low saturations and this thing, the vascular growth will be reduced and the cross-sectional area will be improved. So the best is balanced, but unfortunately, most of you know that, you are a cardiologist, you know that it's very difficult to have a balanced one. You will be between the two, excessive flow and underflow. So the fontan physiology, this is very important to show you. This is the relation between the transpulmonary gradient. Each time the transpulmonary gradient increases, the pulmonary vascular resistance increases, and the pulmonary flow is coming down. This is what I want you to keep it in your mind. I know most of you don't know that, but this is the relation. So there is a steady relation between the increase of the transpulmonary gradient and the pulmonary vascular diseases and the reduction in the pulmonary flow. This is very important relations, and you have to keep it in the mind. So the venous is important, and it's depending on the transpulmonary gradient and the pulmonary vascular diseases. So in the fontan, as you know that the fontan from the beginning is not the good things, whatever it's chronic venous congestions and circulatory failure. With the time, the fontan cannot increase their pulmonary blood flow, so they cannot increase their cardiac output to the optimal one. And in fact, Oxygen consumption during exercise is limited, which is make the fontan is in limited diseases. And exercise tolerance is reduced already by early after fontan completion, and usually it's progressing faster than the normal populations. The failure in fontan is another issue. The failing fontan is because of high BPR, or because of heart failure, or because of obstruction of the pathway, or lymphatic dysfunction. Please, that's why the mission tonight our things is to have to differentiating between these things. High BPR is because of transpulmonary gradient is high, which pressure is normal, ventricle function is normal, no obstructions. And this is the one which is we may, the pulmonary hypertension medication have the role. The heart failure, you have to fix the heart failure and try to improve the heart failure with anti-failure medications. If there is an obstruction, you are talking about intervention or surgery. The lymphatic dysfunction is a long issue, but most of the time, if you reduce the pulmonary vascular resistance, you improve the sign. So this is the most important thing if we are looking for it. You know, there is a lot of changes in all the circulation. Most of the organ is affected, is the lung and the renal, but all the body is affected by the fontan circulation because of stasis or low cardiac output. So in hemodynamic, this is the most important. If you take a patient to the cath lab, try to avoid ventilation, because the positive end expiratory pressure will change the numbers and can give you misleading numbers. You have to look for the collateral blood flow, residual, if there is a residual forward flow, or there is a fenestration, which is also, you have to keep it in mind and reduce, try to avoiding this. In fact, if you can close all the collateral, the better. If there is a venous collateral, which will make the patient's cyanosis, you should close them. The most good thing is to do a pulmonary flow through the MRI and do the pressure in the cath lab. So if you have a hybrid lab, then you can measure that and you can calculate it nicely. The mechanism behind this is very important. We are looking for the low cardiac output, and we know that the fontan is one of the causes, because of if there is no pumping to the lung and there is resistance, then there is the other causes is hypoxia. So the low cardiac output is because of that. They will have a tissue hypoxia. Tissue hypoxia can increase HIF activation, hypoxia-induced factors. And this is hypoxia-induced factors is a group of factors which can increase endothelin, and endothelin is a bad pulmonary vasoconstrictor. It can cause activation of vascular endothelial growth factors, and this is also a growth factor which is always creating more vasculogenesis and also is involved in the pulmonary hypertension. The other one is the erythropoietin activations, and because of hypoxia in this patient, more pulmonary hypertension, more low cardiac output, more hypoxia, and you are going in the vicious circle. So we try all your treatment to cut through this, and is cutting through this is through the green line. Green line is one is fenestration to improve the cardiac output, but unfortunately fenestration can increase the hypoxia. Iron to help in activation of HIF, and also in improving erythropoietin and increase the hemoglobin. HIF blocker is still under investigations. Endothelin antagonist, which is the pulmonary hypertension medications, we are trying to use it. The other antagonist also under research. So this is the most thing which is we have it: endothelin antagonist, iron, and fenestrations. And the iron is very important. It's not just for erythropoietin, but for HIF and activation as a cofactor. This is I'm reaching near to the finish. Patient with single ventricle physiology, effort to avoid pulmonary vascular disease start in the neonatal period. So we try to do neonatal management for single ventricle patient to optimize the pulmonary bed for the fontan. avoid prolonged over-circulation, avoiding pulmonary hypertension, volume-loaded and ventricular dysfunctions. In the Fontan, if they're doing the Fontan, try to close the fenestration or venous collateral to reduce the cyanosis if the patient doesn't need it, as far as you think that the patient is in the safe area. The uses of therapy is in patients with pulmonary vascular disease, which I mentioned before. But the study in the patient with pulmonary vascular resistant, which is less than 2, it is unfortunately the inhaled oxide and testing doesn't change much in the pulmonary vascular resistant. This is very important. Treatment with sildenafil of Fontan failure, including enteropathies or plastic bronchitis, chylus, or severe cyanosis. This is very helpful and really improve it in the patient with BFR more than 3. In the small study in the patient with BFR more than 2, then with endothelial receptors, the bosentan, they also reduce the pulmonary vascular resistance. So endothelial receptors blocker and phosphodiesterase inhibitor may be used when there is a pulmonary vascular resistant more than 2. So the failing Fontan is, as you know, they have a lot of things. I'm just going with the UK studies. There's the recent study. I think nobody talking about that adult congenital heart diseases without mentioning Professor Gardiolis. And this is very important. This is one of them, their team coming from these papers. So the failing Fontan, as you know, this is the list of the things which can come with it. And when they do a survey in the UK, they find this is the indication to use advanced pulmonary therapy. Most of them is exercise intolerance, raised Fontan pressure in around 36 patients, liver diseases, arrhythmia, fluid overloaded, protein losing enteropathy. But unfortunately, around 70%, they don't think that the CAT should be done to diagnose the cases before starting the medications. So by all this cohort is around 5% of the patient of Fontan in the advanced pulmonary therapy. When they study that, the only thing which is changes between the patient, they have a study, they comparing the patient on advanced therapy with the same group with non-advanced therapy. The only changes was in the New York Heart classes. The patient is improving. There is 28 patient was in class 1 and 2. By the follow-up they become 33. So around 5 patients move to in the good side, and the other parameter, oxygens and hemoglobin and albumin, doesn't change. But in fact, if you see the albumin, that almost they are starting with all of them is with the normal albumin, and also the oxygen saturation, all they are started with normal oxygen saturations. So what I mentioned in this, the most important, patient with Fontan and low BFR, advanced therapy may not add benefit. Advanced pulmonary hypertension therapy should be thought about during assessing failing Fontan as a possible therapeutic choice with high BFR. Sildenafil and bosentan are the most common used therapy in patients with Fontan with a good safety margins. Thank you very much.
Thank you, Dr. Omar, for this nice presentation. And the floor is open for anyone to comment or to ask. Also, anybody would like to have his questions to Dr. Omar, to write it in the chat, or he could raise his hand and could give us his comment or question. So I will start, Dr. Omar. I have maybe one comment and maybe one question. So the comment about the Fontan fenestration, we are the fans of the fenestration. Would like the adult patient with Fontan to have fenestration. What we have seen that those patients with fenestration, their liver disease is less, and maybe in expense of the saturation, but all the fontans, they will have desaturation during exercise unless there is severe exercise desaturation during exercise. So usually those patients with fenestration, unless they have significant desaturation or they have paradoxical emboli and stroke, we are not in favor to close. So the questions regarding the advanced therapy in Fontan, we are using sildenafil, but we don't have any experience with others, pulmonary vasodilators and endothelin receptor antagonists. So what is your experience with these two medication in Fontan? Thank you, Dr. Omar.
يعطيك العافية دكتور أحمد. You know that the patient with the fenestrations, this is the theory of pulmonary hypertension, that is hypoxia, tissue hypoxia is in the single ventricle, is stimulation of HIF, and HIF is a big family of growth factors, and this is hypoxia-induced growth factors is creating more of peripheral stenosis and means at the level of the arterioles. And it's in the same time, it is because of, there is no pulsatility. There is another also theory that this is one of the causes of increased pulmonary vascular resistance in the patient with a single ventricle. Now, in using it, as I told you, Dr. Ahmed, that there is, you see that in the UK groups is only 5% of patients with Fontan on the advanced therapy. So that the people, they are a lot of hesitant to start advanced therapy. I know some of them, they are worried about using endothelin receptors, especially the bosentan, because of liver toxicity, and they think that this is worsening the conditions of the patient with a single ventricle. But all the study doesn't prove that this is the most important, is more of the safe medications. My limited experience, I'm not more experienced than the UK and others. Using of them, some of them they are improving, some of them they don't have much changes. So I think that the most important thing is that the patient is the better if you do good hemodynamics and you know that the pulmonary vascular resistance is high or the transpulmonary gradient is high, and there is not a post-capillary diseases, because the experience with the post-capillary diseases, they are getting worse, and also the patient with pulmonary veno-occlusive diseases, which is also they can have it by themselves. So this is the cases which is, I think, for everybody should aware about it. And I think this is the problem with that 70% of the UK people, they don't do hemodynamics. And I think if you select this group of patients with transpulmonary gradient is high, which is normal, pulmonary vascular resistance is high, maybe you will get good result. I think will be worth studying. That is for your question, Dr. Ahmed. Dr. Khalid Al-Umran asking these questions regarding restrictive cardiomyopathy with severe pulmonary hypertension. Is medication like sildenafil useful? This is what's coming in there is two things. Isolated post-capillary, usually the sildenafil will worsening the cases. If it's combined, like there is a post-capillary and pre-capillary, some of the study in adult side, they said that it's improving in some of their symptoms. But unfortunately, it doesn't improve in the survival. In children, I didn't know really how is it. But if you ask me these questions, I have some patient when I was in the National Guard, and in the sildenafil, although they have restrictive cardiomyopathies, later on we discovered that they are restrictive cardiomyopathy. and they are doing fine. I didn't know this is because of sildenafil or this is their natural history, is still alive and doing fine. And this is, I'm talking about 4 years ago. So if you go by the guideline textbook, it's not indicated at all. Okay, any other questions? دكتور أحمد معاي؟ أتوقع أن الآن خلاص ناخذ راحتنا، وإن شاء الله نشوفكم الشهر القادم بanother presentation. وصراحة إحنا نحيي أي واحد عنده استعداد يشارك بأي محاضرة. إحنا فري هابي يرسل تواصل معي أو مع الدكتور أحمد، وإن شاء الله ويسكجول. شكرا وجزاكم الله خير، وإلى اللقاء قريبا إن شاء الله. في أمان الله.